Hello, and thank you for joining me. In this video, we will be providing you with a brief overview of the ICD10CM Codebook 2021 Coding Guidelines, specifically Chapter 9, focusing on the diseases of the circulatory system. When we talk about the diseases of the circulatory system in the ICD-10 book, what we are referencing is any type of category code that falls within I00 to I99. The first topic we're going to cover is hypertension. So, Chapter 9, Section A, hypertension. A key guideline here is that this classification presumes a causal relationship between hypertension and heart involvement and between hypertension and kidney involvement, as the two conditions are linked by the term with in the alphabetic index. So what this means, and we'll get into this further with the specific guidelines, is that we don't need a provider to separately document whether or not hypertension is related to heart involvement or to kidney involvement when a patient has a condition such as chronic kidney disease. So that term with, which we can go back to our coding conventions, that automatically assumes that relationship. So subsection 1, we're going to talk about hypertension with heart disease. So hypertension with heart conditions classify to I50 or I5 1.4 to I5 1.7, I5 1.89, I5 1.9 are assigned to a code from category I11, hypertensive heart disease. And if you go to I11 in your tabular, you will see that it states to use an additional code to identify the heart condition, but the heart condition has to fall within one of these code sections. So it's got to be either from category I50, it has to be between these category values of I5 1.4 to I5 1.7, I5 1.89, or I5 1.9. Anything outside of these diagnoses codes does not qualify for this category I11 code. And I apologize if you can't see it. It's right here. I11, category I11. So many times we will see a provider document that the patient has hypertension and that they have CHF. Well, CHF falls under category I50. So in this case, we will assign a code from I11, and then we will also code our CHF. So these same heart conditions with hypertension are coded separately if the provider has documented they are unrelated to the hypertension. So there are cases where these conditions may not be related to the hypertension, and the provider can specifically document that, and we won't link the hypertension with the heart disease. But if it's not documented as unrelated, you automatically assume that relationship and have to document that relationship. So hypertensive chronic kidney disease. Same scenario as with the hypertensive heart disease. We want to assign a code from category I12, hypertensive chronic kidney disease, when both hypertension and a condition classifiable to category N18, which is our CKD, our chronic kidney disease, when that is present. The CKD should not be coded as hypertensive if the provider indicates that it's not related to the hypertension. So again, same with the heart disease guideline. If the provider specifically documents that the hypertension and the CKD are not related, then we don't code a hypertension code from I12. However, if it's not documented as that, we will assume that relationship because of the term with, which is a presumed relationship. Now, there are situations where a patient will have both heart disease that qualifies under that I-11 code, and then they also have chronic kidney disease. Well, in this case, we have another hypertensive code that provides that combination. This code is I-13, hypertensive heart and chronic kidney disease, when there is hypertension with both heart and kidney involvement. So if heart failure is present, we want to assign an additional code from category I50 to identify the heart failure. And then we also want to assign our chronic kidney disease code from category N18. So if you are using the category code I13, which please note this is a category code, meaning it's not complete, it's missing characters. If you are using this category code, you will also pick up the heart failure, if that is what the diagnosis is for the heart disease, and CKD. Now we have many other conditions that could be related to hypertension. Okay, so in those cases, we need to make sure that our provider is giving us that documentation. So if you read starting at section 4 all the way down, we do have different types of hypertension, and it provides the category codes for you and the guidelines to code it. So please make sure that you do read through each of these individually. Want to cover hypertension controlled. So this is basically just stating that chronic hypertension is under current medication therapy and it is under control. So again, this would still code out to basically regular hypertension, whether or not it qualifies for a combination code or not. There is not one that specifically states hypertension controlled. Uncontrolled hypertension, this is when our patient may not be responding to that medication regimen. They are having basically an exacerbation of their hypertension. It's pretty high, higher than normal. Again, we don't have a specific code specifically stating hypertension uncontrolled. So again, you'll fall within the categories I10 to I15. Now we do have a hypertensive crisis. So we want to assign a code from category I16, hypertensive crisis, for documented hypertensive urgency, hypertensive emergency, or unspecified hypertensive crisis. So code should also identify the hypertensive disease. The sequencing is based on the reason for the encounter. So what this is telling us is, depending on whether or not the patient has hypertensive urgency, emergency, or hypertensive crisis, we will assign a code from I16. If the patient is also noted to have hypertension, chronic hypertension, we can assign an additional code for that, because hypertensive crisis in these two other subsections under hypertensive crisis, these are basically the way that we are going to code out a patient who is having that type of exacerbation. But the provider's got to document it as such. So they got to say that it's hypertensive crisis, patient's in hypertensive urgency or emergency, and then the provider may say the patient has known hypertension on lisinopril. Okay, so if that's the case, again, we're going to code I16, a code from here, and then we can code our regular hypertension disease code, which if it's not with heart disease or CKD, we would just assign I10 to as the secondary code to the I16. Pulmonary hypertension, this is classified to category I27, so other pulmonary heart diseases. For secondary pulmonary hypertension, code also any associated conditions or adverse effects of drugs or toxins. So again, pulmonary hypertension, to get that specificity you need to make sure that it's in your documentation. So your provider has to document it as that. Atherosclerotic coronary artery disease and angina. So there are combinations for ASHD with angina. The subcategories for the codes are I25.11 and I25.7. So when we use one of those codes, we do not need to code the angina out separately, okay? And a causal relationship, apologize, kind of blurry. A causal relationship can be assumed with a patient with both atherosclerosis and the angina pectoris, unless the documentation specifically states that the angina is due to something other than that atherosclerosis. But if the provider is just documenting that the patient has angina and they have atherosclerosis, you can automatically assume that relationship and code that combination code. If a patient is admitted with coronary artery disease due to an acute myocardial infarction, the myocardial infarction should be sequenced before the coronary artery disease. Okay, so let's talk about CVAs. So as you know, a CVA is another term for what we call a stroke. And if you're familiar with any type of stroke patient, you will know already that there are residuals that these stroke patients can have after they have a stroke. It could be a deficit within the musculoskeletal system where they are paralyzed on one side of the body, or it could be like a facial droop, a foot drop, any of those. So what this is called when this happens is a sequelae of cerebrovascular disease. So it's a late effect of that CVA. So for those late effects, we have specific conditions that we can code to capture those late effects. And we're going to talk about codes from category I69. So these codes specify when a patient is suffering from hemiplegia, hemiparesis, or monoplegia that is a late effect of a CVA. And just like you learned last week, we're going to apply the same concept of the dominant versus non-dominant because of it being a hemiparesis. So even though it's hemiparesis, we're not going to use those G codes. Since it's a sequelae of a CVA, we're in I69. So there is a separate code for this type of condition, but the guidelines follow the same. Left side's affected. It's not specified as being the dominant or non-dominant side. Our default will be that it's the non-dominant side. If the right side's affected and it's not specifically stated that the right side is non-dominant, well, the default's going to be dominant. So same type of guideline you already know from the previous chapters or the previous video, and we're just going to apply them under category I69. Okay, so let's talk now acute myocardial infarctions. So acute myocardial infarctions, also known as AMI. So there are many different types of acute myocardial infarctions. We have ST elevations, we have non-ST elevations. We can get specific with the site that is affected by the myocardial infarction. So the first guideline that we want to talk about is when we code I214. So we want to use I214, non-STEMI MI, is used for a type 1 non-ST elevation myocardial infarction and transmural MIs. Now, just to go back up, for type 1 MI, we want to identify the site, such as the anterior lateral or true posterior. So subcategories I2 1.0, I2 1.2, and code I2 1.3 are used for type 1 ST elevation MIs. So there is a difference there. So if a type 1 non-STEMI evolves to a STEMI, we want to assign the STEMI code. If a type 1 non-STEMI converts to a non-STEMI due to a thrombolytic therapy, it's still coded as a STEMI. So basically a STEMI is our more severe condition. We do have an unspecified MI code, so we would use code I2 1.9, acute MI unspecified, which is the default for an unspecified acute myocardial infarction. Subsequent acute MI, so a code from category I22, subsequent ST elevation, so that's our STEMI, and non-ST elevation, non-STEMI, MI, is to be used when a patient has suffered a type 1 or unspecified AMI, has a new AMI within the 4-week time frame of the initial myocardial infarction. Now, this is one thing that you do need to note, that there is a time frame within these myocardial infarctions, and it's 4 weeks, okay? Because if it's within 4 weeks, it's still going to be considered current. So a code from category I22 must be used in conjunction with the code from category I21. The sequencing of I22 and I21 depends on why the patient came in, what the reason for the encounter was. So make sure that you read through this thoroughly so you do understand it. In our last guideline I just want to go over is other types of myocardial infarctions. So as I mentioned, we have many different types. Okay, so type 1 myocardial infarctions are assigned to I2 1.0 to I2 1.4. Type 2 myocardial infarctions are assigned to I2 1A1. Myocardial infarction type 2 with underlying cause would be coded first. We're not going to assign I2 4.8 other forms of ischemic heart disease for the demand ischemia. If a type 2 AMI is described as STEMI or non-STEMI, only assign code I21.A1. The codes I2 1.0 and I2 1.4 are only assigned for type 1 AMIs. So acute MIs types 3, 4A, 4B, 4C, and 5 are assigned to I2 1.A9. So this is an other myocardial infarction type. And also pay attention to your instructional notes, as we have the code also, and code first notes should be followed related to complications and for coding post-procedural myocardial infarctions during or following cardiac surgery. So always read your instructional notes in your tabular when going back to verify any type of diagnosis code that you are researching. Those are a brief overview of our Chapter 9 guidelines for the circulatory system. Thank you for joining me.